Well, right heart catheterization, of course, goes back to the very early days of hemodynamic assessment to assess valves and so forth. And it was believed that with every heart catheterization, even for coronary angiography, a right heart catheterization should be done. I go back to the mid-70s, and we did right heart catheterizations on everyone. Then the idea came that if we could measure that pressure at the bedside, it would help with patient management. Jeremy Swan and Willie Gans developed the Swan-Gans catheter for right heart measurement. And this flow-directed catheter became very popular and actually provided tremendous understanding of mechanisms of disease and treatment. The problem was it got used and overused, and it was used and kept in too long, and there were complications with that, and it somewhat delayed treatment even sometimes because everyone was trying to optimize a particular number. So after some studies, it was decided that it was really not very effective and wasn't always useful. So the use of the right heart catheterization, and particularly in the setting of acute circumstances, dropped tremendously. What's changed today is that the right heart catheterization is now starting to increase slowly in patients with cardiogenic shock. And that seems to be associated with an improved outcome for those patients. So it looks like it's now finding its rightful place and is really critical in the management of the patients, particularly those on hemodynamic support, because most of the hemodynamic support has been focused on the left side. And so when you suddenly improve function on the left side, you can sometimes, either because of change in shape of the ventricles and the association of the right and left ventricle, or because of changing hemodynamics, bring out right ventricular dysfunction. And some of the limits to the left heart function then will be the right heart. And so the ability to measure that. A study that's ongoing in the United States looking at acute MI and cardiogenic shock has shown that information from the right heart catheterization, particularly regarding cardiac power index, cardiac power output, is very crucial to knowing how much support you need, when you need to escalate, and how these patients will do. So I think we're now seeing an adjustment from going from all to none to now clearly a greater use, particularly as we switch from the use of balloon pumps for cardiogenic shock support, which is now really becoming out of favor, to the more powerful mechanical circulatory devices.